Next, we have Dr. Xi Yin Goai. Dr. Goai is a resident medical officer in her second postgraduate year at Mackay Hospital and Health Services in North Queensland. She graduated in 2019 from Monash University in Malaysia with a Bachelor of Medicine, Bachelor of Surgery. Dr. Goai has a keen interest in regional and rural surgery. She's got 3 previous publications and aspirations to enter surgical education and training program. Welcome, Xi Yin.
All right, can you hear me now?
Yes, we can. Thank you.
So good day, I'm Singh, surgical resident from Mackay-based Hospital, Queensland, and thank you for this opportunity to present our case series surrounding 4 patients with a complicated sequelae of reconstituting subtotal cholecystectomy. This is a daily scenario in Mackay-based Hospital, a hot gallbladder in a morbidly obese patient, 400 kilometers from the nearest tertiary hospital with no on-call radiologist. Cholecystectomies represent a substantial proportion of acute and elective surgical cases with a major risk of bile duct injuries. Whilst open cholecystectomy would traditionally be the gold standard in cases of a difficult gallbladder, few trainees are exposed to this technique as an elective operation. They're usually performed as a bailout procedure whereby the trainee is unlikely to be the primary operator. Subtotal cholecystectomy has been implemented whereby a partial cholecystectomy is performed and obstructive gallstones removed, thereby alleviating the septic focus. And whilst this technique may prevent bile duct injuries, it comes with several major pitfalls. We present a case series of 4 patients with 3 different complications post-subtotal reconstituting cholecystectomy. They present at variable timings from 4 months to 30 years post-operatively, and all patients requiring difficult redo cholecystectomy. Case 1. A 35-year-old gentleman was readmitted 4 months after his cholecystectomy with jaundice and right upper quadrant pain. Decision for a subtotal approach was made then to avoid a bile duct injury. MRCP confirmed a remnant gallbladder, we call it Ocalophysis. The patient underwent a difficult open redo cholecystectomy with common bile duct clearance. A shrunken and fibrotic remnant gallbladder was encountered, and after careful dissection and adhesiolysis, a successful cholangiogram was obtained. He was well post-operatively with normal liver function values at his 3-month clinic review. Case 2. A 61-year-old female presents with pancreatitis 1 year after her subtotal cholecystectomy. A long cystic duct stump was left in situ to prevent a bile duct injury. CT scan showed diffuse fatty infiltration of the liver, a common bile duct of 8 mm diameter, and a cystic duct that was dilated to 22 mm. MRCP demonstrated a remnant or neo-gallbladder containing sludge and stones. She settled with conservative management but developed worsening LFTs on day 3 and thus underwent ERCP with sphincterotomy. Given her overall fitness and risk of recurring symptoms, the patient underwent laparoscopic redo cholecystectomy. The procedure was challenging due to dense adhesions upon entry and between the neo-gallbladder and the porta. With assistance from a senior hepatobiliary surgeon, the operation was successful and the patient made an uneventful recovery. Case 3. A 74-year-old female presents with right upper quadrant pain and fevers. She had a history of open cholecystectomy 30 years ago. She is morbidly obese and was bedbound in her nursing home. CT scan and MRCP demonstrated a remnant gallbladder with stones, but no Ocalophysis. She was treated with intravenous antibiotics and settled during the admission. An open approach was utilized for her elective redo cholecystectomy. This was complicated by a shrunken and fibrotic remnant gallbladder packed with stones and sludge, and within dense adhesions with the common bile duct and common hepatic duct. She made an uneventful recovery and was well during her 6-week clinic review. Case 4, an 81-year-old male with a background of metastatic renal carcinoma presents 4 years after his previous subtotal cholecystectomy with epigastric pain and a raised lipase. He had a good long-term prognosis due to targeted therapy, and after being extensively worked up for other causes, MRCP demonstrated an absent gallbladder. We call it Ocalophysis, and complete removal was achieved via ERCP. Due to concerns of a biliary remnant and risk of recurrence, the patient subsequently underwent laparoscopic completion cholecystectomy and biliary exploration. Dissection was again complicated by fibrosis and a densely wielded omentum to the porta, requiring an hour of careful adhesiolysis. He made an uneventful recovery and was discharged the next day after removal of surgical drain, and he was well during his 4-week review. Subtotal cholecystectomy can be performed in cases of severe cholecystitis, Merz's syndrome, and where portal hypertension may jeopardize safe dissection of the critical view. The fenestrating subtype leaves a risk of biliary fistula, often necessitating post-operative ERCP. Also, if the cystic duct is uncontrolled, the omentum eventually plugs the defect and creates a neo-gallbladder. In the reconstituting subtype, closure of fundus effectively creates a neo-gallbladder. Whilst the immediate problem of acute cholecystitis may be solved with these strategies, risks of complications from the remnant gallbladder increases in the long-term post-operative period. We recommend that patients must be informed when a subtotal cholecystectomy is performed and to seek surgical advice if symptoms recur. If unable to obtain safe critical view, open cholecystectomy should be preferred with a surgeon who is experienced and or with aid of a hepatobiliary surgeon or senior surgeon. As a last resort, gallbladder drainage is utilized with aim to seek hepatobiliary advice. Again, subtotal cholecystectomy should be reserved as a last resort strategy due to risks of recurrence and complications in the long-term post-operative period. An open conversion should be preferred and or assistance of a second experienced surgeon. Thank you.
Thanks for your presentation, Xi. We do just have some questions from the audience. First of all, question was, were the stones left from the initial subtotal cholecystectomy or did they develop subsequently? If left from the initial operation, how important is removal of all the stones as a critical step in subtotal cholecystectomy?
Yeah, so in the initial operations, all of the stones were cleared out. And even in the first case, an MRCP was performed after the initial subtotal cholecystectomy to rule out any stones before discharging the patient. So it's important to remove all obstructing gallstones and any stones in the ducts to alleviate the symptoms and remove the septic focus.
Can you tell me what proportion of those cases that you present, overall, how many subtotal cholecystectomies were done over that same time period? What proportion do these represent?
Yeah, so we had approximately 10 subtotal cholecystectomies that we could find performed in the base hospital, and 4 of which recurred.
Okay, thank you very much, Xi Yin. I don't think we have any other questions at this point in time. Thanks for your presentation.